past medical history would certainly be important. An orthopedic surgeon, I might ask him about seizure disorders. What medications, if he doesn't remember medications, I'm sure he'll remember that he's had has or hasn't had a seizure disorder. And so I would ask something like that.
I agree. Past medical history would be helpful. Cardiovascular issues, any arrhythmia history.
From his elbow, he could have a contusion to the elbow.
Which could result in
Yeah.
bursitis.
Bursitis.
Sure.
So could have a fracture, but obviously it sounds from this that I hope they've done X-rays. He doesn't have any fractures, so he just has a little swollen burst on the back of his elbow.
The cervical injuries, looking at that mechanism, depending upon how he hit his head, could range anywhere from a cervical sprain to a fracture.
It's fairly limited, though. I mean, there's a lot of information that could be missed by just this paint drawing.
And
Which I
since
think
he
is
doesn't
pertinent.
remember falling, he
Right.
can't really give you a mechanism of injury.
Yeah.
The current symptoms
Well, you know
outside of these.
he's hit the back of his head, so he immediately has a flexion injury
Right.
of the cervical spine, and that's certainly, depending upon how he could jump facets, fractures, disc herniation, any range of injuries to the cervical spine.
start with a baseline somewhere, I guess, if I'm not a doctor.
So none of these employees have baseline studies generally. In sports now, we're doing some baseline testing, but it's rare in the workforce that any of these patients have baseline. And even the baseline is questionable on how accurate that testing is in terms of cognitive testing. And unfortunately, where things currently stand with the data and the technology, there are very limited options to objectively evaluate patients with mild traumatic brain injuries in terms of objective evidence. They have lots of subjective complaints. There are some things currently being done. There's some imaging that looks at the pathways, the white tracts in the brain that are suspected to be damaged even in mild traumatic brain injuries. But that testing is done primarily in study settings, in university settings where they're doing testing, and it's not really prime time imaging. It's very expensive. There are functional MRIs. There's diffusion testing that can be done. But again, that's not something that's commonly done. And so we're limited in imaging. Mild traumatic brain injuries, it's going to be a negative study. CT scans, MRIs generally are going to, basic studies are going to be negative. There are a lot of studies being done to see if there's some other physical exam. Saccadic eye movements are being looked at as a possible test to be done. There's some various tests that can be done to determine how that correlates with diffusion tensor imaging. But again, not yet there. There's even a blood test that's being considered as a possibility. But right now, we really only have our physical exam and our imaging, basic CTs and MRIs that are generally negative in this kind of mild traumatic brain injury or concussion.
What about bringing them back like on a light duty job, rudimentary tasks per the doctor's approval, monitoring that, see how they respond to simpler tasks?
So
that'd be something we could do.
the standard of care, what I would say is that, and a lot of this comes from the sports medicine literature, but I apply it to workers. I look at workers as athletes in many cases, and the standard of care for managing these patients is initially a period of cognitive and physical rest, which is reasonable. It's what's in the literature, it's what's supported, and so there is a period where the patient does need to be monitored and have a period of rest, depending on what their complaints are subjectively, what their exam is like. But you're correct that in the sports literature, we gradually advance patients from very light activity or limited activity, advance them with aerobic activity. This is where physical therapy comes in a great deal. And I have some protocols that I use to try to gradually advance workers, similar to how they're advanced in the sports medicine literature. And you're correct in that monitoring is key. So I use physical therapists to advance these patients, check their vital signs, blood pressure, their pulse, monitor them before and after the symptoms they're having. If the symptoms worsen during exercise, then that is a concern. And also, it gives us objective information from the therapist on what's happening with these patients. Are they coming in joking, looking fine, saying they have headaches, but there's no objective evidence that they feel bad? Their dizziness is often the common complaint, and are they sometimes dizzy and sometimes not? That doesn't fit. And so I use therapy a lot in these cases.
There's a lot of research being done right now with therapy and these type cases, and what they call vestibular rehab, which is really looking at the dizzy issue and looking at their eye tracking, the saccades that Dr. Tripp mentioned, and doing interventions and therapy that really work to improve their eye control, their balance. We have to look at their neck. This did talk about neck pain. You do have to rule out that dizziness can come from your neck as well. And then obviously, looking at their activity tolerance versus their symptoms, but more than just activity, but work activity. So simulating the work in therapy to say, this is what they're capable of doing. Again, that's where that job description is helpful. So we can give that to Dr. Tripp or any of the doctors and say, this is what we feel they can do safely based on their symptoms, based on their vital signs, so they can let you know, so you can bring them back in a safe manner.
You ask about testing, even with regards to the football players. And even the baseball players do too, they do testing prior to the season. So if they have a concussion during the season, they have this cognitive testing. But even with that cognitive testing, you can use that to show that they don't have any cognitive issues after the concussion, but you can't allow them to play if they still have symptoms. So that cognitive test can help you if you have some baseline. But even if their cognitive test is normal and they complain of subjective complaints, as Dr. Tripp said, it's impossible for you. I mean, if I say I'm dizzy when I stand up and you say I'm not, who's to say I'm not dizzy? And even if my cognitive tests are normal, if you're a football player or baseball player, you're not allowed to play until you don't have any symptoms. And you can progress your activities or progress, going back, starting to run, starting to increase your heart rate and all these other things. And once you can do those things, then you can start doing sport-specific drills and you can start doing contact drills if you're a football player. But if you can't do that, it doesn't matter. And I can tell you, I played football in college and we had one of the players I played with who had 3 concussions in one season, and it was over. He didn't play anymore. He's a great linebacker, but he just could not get, he said, and his cognitive test, he was an engineer. I mean, he did very well in school, but he just said, I just don't feel normal. I don't feel like I can do this anymore with regards to playing a sport. So I think it becomes almost impossible, I would say, at some point to figure that out, especially in the workforce with somebody that has this type of problem.
And just to educate you a little bit, there's no data that demonstrates the level of force. It can be very minor, so you can't say, oh, he just bumped his head and didn't sustain a concussion, if you will. You can do imaging, this advanced imaging that I'm talking about. You can see changes that occur even with minor head trauma, what we would consider minor. You can see neurochemical changes, pathophysiological changes that occur. So it's very difficult to correlate injury with outcome.
Is it easier to get another concussion once you've had a concussion?
He's already had some, so it's very easy.
Yes.
If you're young and your brain is immature, so younger individuals, if you've had concussions before, if you have any type, like if you have ADHD, you're more at risk. If you have there are other things, depression, other things like that put you at increased risk for
Learning disabilities.
learning disabilities.
Family history, even migraine history.
Yeah.
There are correlations with outcome as well.
If you think that the person is not telling the truth, just based on your experience, is there anything that you would, as a defense lawyer, tell us to look for? Or I know the next question that Pat then took down was surveillance. But from my perspective, some of these people, because the symptoms are difficult to subjectively or objectively quantify, it becomes a self-fulfilling prophecy. And if we do surveillance, we may not have any success because they believe what they're thinking, or they're really injured. I mean, it's hard to say.
So I think the best advice I can give to all of you is that because this is such an issue now in the media, there's so much attention to it, there's so much Google Doctor and so many things that people can find, and this is going to be the next big litigated issue, no question about it. You have to get these patients to specialists right away. You cannot sit on them. They need to be treated immediately so that at least in your defense you can say we went through the proper channels, that they had the proper care, the physical and cognitive rest, that they were treated by a specialist. I think that is going to be your best defense in terms of treating them appropriately from the beginning. Outcomes do show that often if they are treated early and they get the rest they need, they will improve. The data is, the data demonstrates that most concussions related to sports, people get better within 7 to 10 days. Now in our world, of course we're not seeing that, but the data also supports that a third of people do continue to have symptoms. So it is a real phenomenon that people do continue to have some symptoms. It's certainly magnified in certain populations, motor vehicle accidents, work injuries, and so forth. But who is who? It's fairly impossible to tell. And what will help us is if we get imaging that's ready for prime time, that we can do, that's not cost prohibitive and available in major centers. And if we have some lab tests or other physical exam tests that correlate if they're positive tests.
What would you say the normal rest time is before you start therapy?
So the literature supports that it's appropriate to wait as long as 3 to 6 weeks before. Patients may recover before that, and therapy is not necessarily needed. So I might consider giving that patient a period of time. I'm not saying they're off work for 3 weeks, but I may watch them for a short period of time, have them just resting. You do have to be careful about starting too much therapy too soon. And so the literature supports a period of waiting. And, I might start, by the time folks are getting to me, unfortunately, that period is often already subsided. But we're well past 3 weeks. So sometimes I don't have that decision to make. But I think, and you have to have the right type of therapist and therapy. It's not just plain usual physical therapy. Well, I think in this case you do have some objective data. The neuropsych evaluation, and again, you're going to see more requests from specialists for neuropsych evaluations because that's going to help, at least on the cognitive side. And as you saw, they do a lot of psychological questioning as well. So I think that it takes a while to get into these folks. It's an expensive test, but it's worth it to get that study. Now, you have to have a physician order it in the right timing. It's not a test that should be administered early in the course. You want some delay in that to have the best recovery for the patient and the best outcome. But I think if you do surveillance, and this individual's giving a lot of complaints about not being functional, yet he's driving and he's working in the yard and he's doing a lot of tasks, ADLs and further things that would suggest that this isn't all factual information you're getting.
How does a case manager, claim adjuster, attorney handle a case where all medical providers have released him to work, but the employer states they don't trust his ability to work and they keep sending him home, he has no work? But we know what the claim adjusters are doing. What are they doing? Paying TTD. They can't send them to doctors because doctors keep coming back with what we've seen, and there's no place else to send them. So what do? Attorneys think, what do? John?
Well, we have multiple physicians saying maximum medical improvement. In Missouri, unlike Illinois, we don't have wage differential. We do not have to provide mandatory vocational rehabilitation. In Missouri, vocational rehabilitation is not mandatory. We have, I think, 3 or 4 excellent physicians in this case, including a neuropsychologist who have said maximum medical improvement. So Pat, there's a tough decision to make in terms of the human resources employer decision, but in terms of putting on the blinders and talking about workers' compensation, we are at a point where we have gone overboard for the employee with all of these different specialists. He's reached maximum medical improvement, so from a workers' compensation point, the employer would be more than justified in terminating benefits. But that also brings in the human resources question. So perhaps the best blend would be to possibly terminate benefits and then work with the employer to bring him, I think Dr. Tripp mentioned this, bring him back to light duty and then gradually bring him to a more full position as time goes on and on. So you satisfy the human resources component, and you're also satisfying your workers' compensation adjuster by terminating benefits, because we have more than ever hit the ball back in his court to say, we've taken care of you very well, so employee, you show us by producing physicians' reports indicating that our physicians were wrong, and we'll take it one step at a time.
So here's the nightmare. The nightmare with this employee is, and could be, I can't go to work because I'm afraid I'm going to get so angry that I'm going to hurt somebody. Now, in this day and age, does that not raise a bunch of red flags? So you got a lot of employers saying, I'm not putting him back at all. I don't care what the doctor says. This guy is telling me he's angry and he could hurt somebody. He's afraid that he will go off and hurt somebody. Now, we have enough evidence to say this guy's probably, faking some of this and exaggerating. So we're going to have to fight it on that end. But this is a tough case. This is a really, really tough case to manage. It's the first one I think we've ever had that's gotten this messy where there are so many unknowns. The only thing, and there is one that we haven't applied yet. Everybody hear the green poultice?
Mm-hmm. That's right, cut your losses.
Yeah. Green poultice. Green poultice was used, give them a little bankroll of money, and amazing how quickly they get. So about the only way out of this, and we've discussed this, is trying to get with hopefully they have an attorney. And in this case, they do. You take your attorney, that attorney, get together and kind of find out where can we come to some agreement. Because I guarantee you, the plaintiff attorney is going to go crazy with this patient because this patient's driving everybody nuts. So they're going to want to come to the table at some point. You just got to figure, how much loss do I want to take to cut this thing loose? Because there's nothing else we can do with this.
Does the employee want to come back to work?
No.
Well, if the employee doesn't want to come back to work,
I mean, that's easy. I dovetail what John says. If the employee does not want to come back to work, he's released at MMI. We've done everything we can do. What we can out and out is terminate someone for pursuing their rights under the workers' compensation statute, but that doesn't appear what's happening. You hope. You don't want, you walk that tedious line there.